Thank you. So what I'd like to do now is call up Marie and Maria and Steve. I didn't see Steve.
Actually, I didn't see Steve.
Okay.
Both Steve's abandoned
So
me.
Steve Ornish has abandoned you, yeah, and your first Steve did. Do we have somebody that would like to join Maria as one of the discussants? Come on up,
Thanks,
Barbara.
Barbara.
Great. So what I'd like to do is turn it over to Maria and Barbara to comment on what they've heard in these two talks thus far. We'll ask Carla and Dave to come on up as well and have some interaction with the audience.
So essentially on the mentorship talk, I actually wanted to tell you a story that is a combination. Thank you, David, for telling us, the turbulent waters that we have to go through. I've been a mentor of some of the residents, and let me tell you the story of two different reactions. And this is where you should know your limits, understand your limits, know what you can and cannot do. I mentored a female resident who had very difficult interactions with certain attendings and her class, actually. And I was seeing her every week from second year to fourth year. And then fourth year, it was not every week anymore because of the various different rotations she has had. Well, let me tell you that she is still in contact with me. She is still appreciating that. And I think she was able to navigate. And actually, I believe she apologized for not being for being a very difficult resident. She apologized to the attending. So that is one example. Another example is someone that I was also asked to mentor. I'm not his mentor, but there were some difficulties that he had encountered with nursing staff, with his work. And I couldn't budge. He was just difficult. After a couple of sessions, we decided that it was not a good thing. So he's still here. So I thought he was going to leave because he threatened to leave when I first saw him, that he was going to leave the program. It was not what he expected and all of that. But it was so hard because, first of all, I think it was because I'm a woman, and I think he has issues with the female. So that, Dave, is really what you mean, right? Know your limits, know when you should give up. Okay. And then with Carla, in terms of the motivational interviewing, I really feel frustrated and with certain people that I supervise. And it's very, very frustrating when you can't get them to understand what you want them to do. And thank you for those tips. I think I'm going to use them and let's see if that works. but it was so difficult.
We should do some more training on actually what some of the tips are. I was just advocating that it's a good thing to try when you're frustrated.
Okay, I have your book. So I should read it though.
Which is now in Hungarian.
Oh, okay. No, but really, I think it's important to use those techniques with residents, with trainees, in general conversation with your supervisees, people who you want to make them do certain things and try to find a way to make them do it without antagonizing them. So thank you for that. And Barbara?
Well, what comes to mind is, there's this film, I don't know if many of you have seen it, the film on Burnout. I think you circulated it recently. And the theme of it was burnout is not an appropriate term. It really should be moral outrage. Moral injury. Moral injury. And the point was that, like most physicians are trained, as you emphasized, to take care of people. They go into medicine. They're caretakers. They want to help heal people. And just with all of the bureaucratic resistance that they encounter and overload, that they can't do that. Mm-hmm. And the individual speaking was, I think the term outraged was probably appropriate in that this person was very outraged that this term burnout was being applied to them. And I thought Sid had a good comment that this is, there's some points that are well made, but it more emphasizes, it was sort of a setup between sort of like physicians and house staff and administrative. And it sort of more emphasized the distinction between them. It was more, as the Jewish theologian Martin Buber would say, more of an I-it than an I-thou relationship, which I thought was, maybe the point you made. But I thought one of the points that was good about it, that at least in my experience in working with other people, is that there's often this attributional error made. That, I've had this, if you can't, manage to see all your patients in 20 minutes and then do your 24 minutes, you're given, I was told in my first MOU, I had 24 minutes, between 21 and 24 minutes to see the patient and 6 minutes to write the note. And I asked, well, what happens if somebody gets suicidal at 23 and a half minutes? And it's not like you're, and I wasn't being a team player if I was bringing up those kinds of issues. But the point is that, and so then you're accused of being too slow or not efficient enough or not having good time management skills. And that's really what the neuropsychologist, as I would call it, an attributional error. It's not the fault of the individual, there's a fault in the system. When you're expecting physicians and to see patients and do their computer work. I remember being told by one of the unit leaders at the VA that I was supposed to assess suicidality by, sitting on the computer and asking them the questions. No eye contact. Yeah, but I've had patients who, when I've referred them out, they were outraged that, the physician came in, just sat down at the computer, didn't look at them, changed their meds, was drinking a Coke while they were looking at the computer. So I think that the value of that film, there is an attributional error when it's blamed on the house staff, and I think that's one of the factors that leads to burnout. Because you're trying to do a good job, you can't with all the loads. And so to put and I've also had patients outside this institute with other institutes who are just, so overloaded. And they're told, oh, you need to have you need to have more meetings. You need to have more meetings with your supervisor. You need to have more, you look like you're burned out when you're teaching, so you need to go to a teaching seminar. That's not going to help somebody who's already, spread in so many different directions. Yeah, so, that was the point. I just think that this, like to emphasize what you were saying, you just can't change the individual so much when the system is so overloading them. And as Valiant said, he did the study of coping strategies in male Harvard men, and they were, the best coping strategy was TGIF.
Okay,
So,
Dave?
yeah, I just two brief things. One is, I gave you the extreme example of giving up. I'm not endorsing that. I think it's calibrating your goals. This has to do with within a motivational context. It's calibrating your goals so they're reasonable. So I didn't mean that to be misinterpreted. The other thing that's come up implicitly in some of these talks, that I don't know how much has been discussed over the entire day, that we are still living, the medical community is still a rather misogynistic community. I found that in my work with Society of Biological Psychiatry and ACNP, that it was relatively easy to move things in a direction of gender, sex equilibrium and equality. So that's one major issue that we have. The other one, which is very trenchant, is underrepresented minorities. With women now are in the pipeline. We still need to make a lot of adjustments in terms of recognizing institutional problems. One major problem that we have not been able to address across many places, including UCSD, I think, is underrepresented minorities, because they're not in the pipeline So I always say we should take the $700 billion military budget, take a third of it, and put it totally into childhood education and health. Because that's the only way. You have to grow. The roots aren't there, then the roots aren't there. And so that's a real strong interest of mine, and I got this NAMI Inspiration Award for stuff I've done in trying to get people to understand that it's early childhood education and early childhood health that'll allow underrepresented minorities to flourish in our system. Because they're, as badly as women have had it, that group has had it even worse. So I think we have to keep both things in mind.
So I'd like to, and Carla, you had one thing you wanted to say? And then
I was just going to make a quick comment on your comments on moral injury and the systems that are at play that we have to work within, that oftentimes we don't have a lot of agency to contribute or control in those, but what we can do is how we relate to them in certain ways, and how that can sometimes take that burden off of you of feeling that you're grinding your gears against this intractable system, but that you do have a little bit of control over how you can relate to that. That can sometimes be helpful, at least for me, in terms of thinking about when I get so frustrated, what are reassessing my goals and how I can relate to that in a way that's helpful.
Thanks.
So I want to take the prerogative of asking one last question to Dave, actually. So Dave, all of you know, is for the last couple decades of his life has been a preeminent researcher, and his major identity in the field is as a researcher, and he's won many national awards as a researcher. 20 years from now, when you're ready to retire, what do you think will have the more lasting impact on the field, and what do you take the most pride in? Your research findings or the mentees that you have worked with?
So Leonard Cohen, in his concert in London, said, he was 75, he said, I haven't been at Royal Albert Hall in 15 years. Back then I was just a 60-year-old kid chasing a crazy dream. I don't know the answer to that. I do know one thing for sure. When research, as it always frequently is frustrating. Like the work I'm doing with Greg Light out at Alpine with chronic patients on neuroplasticity and rewiring the brain, to me, is really exciting. That may pay off in the short term. I'm not so sure. When I'm really frustrated, I always have something to fall back on, which is the incredible mentees I've talked about and the patients I've helped. I think that gives me, as a researcher, a lot of, I don't know if solace is the right word, a lot of comfort. And I often wonder, if I didn't have that, would I feel like jumping off a bridge somewhere? Just kidding. Okay. I don't want anyone to 5150 me.
With those inspiring
Do you want me
words.
to ask
But I
you a
don't think
question,
we.
Errol?
I don't
I'm
think
looking at the
that's
computer.
the issue. I don't think we know, because we're so early. I wrote this thing with my daughter for JAMA, Psychiatry. We're very early in this translational revolution. The things that we've talked about today are things that we can do now, and I think that's what we have to rely on. Those are the real arrows in the quiver. I don't know much about the motivational aspect of things. That sounded great. Like I learned something too. So we do have tools that will work now.
Well, thank you.